The yellow crystal represents the debris in the long arm, while this green one shows you in the non-ampullary arm. And when we do the Dix-Hallpike, you can see both of them have different paths, and hence the nystagmus will be different. So when you do skip this. So when we do the Dix-Hallpike, we have to be able to identify what kind of nystagmus it is. So if it is in the long arm, you would get this kind of a torsional upbeat nystagmus when you take the patient down, and when the patient comes back up, there will be a reversal. And in this kind of a patient, we would prescribe the Epley maneuver. So the Epley maneuver, here you can see actually what is happening at each step. So just like the Dix-Hallpike, turning the head by 45 degrees and going down 30 degrees, you can see that the crystal goes to the most dependent position. It's very important to wait at each position for at least 30 to 40 seconds to allow the debris to reach the most dependent position. And then we go to the next. You turn the head by another 90 degrees, and here you can see that it moves further through the canal. In the third step, we are going to go to the nose pointing down position. So here you can really understand what we do is clinically, but whatever is happening is actually inside the head, inside the 3D labyrinth. So this just helps you understand why are we doing these maneuvers, why we need to do the angulations correctly, and why we have to wait at each step to allow the debris to reach the next correct position. But suppose I got this kind of a nystagmus in which it is again a torsional upbeat nystagmus, but here in the VNG graph you can see that this nystagmus went on for over a minute. Canal lithiasis is typically, as Dr. Prem Sagar told you, has a crescendo, decrescendo pattern and usually is over by 30 seconds. But if the nystagmus lasts for more than a minute, that means it is cupulolithiasis. That means the crystal is adherent to the cupula. And for such a patient, we would need something to dislodge it from the adherent cupula. That means we need some form of inertia. And though Simonds works well for the canal lithiasis as well, but it is absolutely indicated if you see a cupulolithiasis. So here you are turning the head by 45 degrees and going to the side lying position. Hold it for about 30 to 40 seconds or till the nystagmus subsides, and then you swing the patient by 180 degrees. Here we are using inertia and gravity to take the patient and allow the crystal to move to the other part of the canal and then out. Now, in this paper by Professor Obrist and what we call the Simond plus maneuver. So when you go to the side lying position, you add another 30 degrees. And here in the simulation, you can see that the crystal moves further through the canal and it actually crosses the curvature. And now, when we go to the opposite side, you are having a 180 plus 30 also, so you're adding to it, and then the crystal is sure to move further, and there will be less chances of failure because the crystal has actually already crossed the curvature and it really needs only gravity to now take it further. Now suppose I did the Dix-Hallpike and I get this kind of a nystagmus. This is just downbeat, pure downbeat nystagmus. So as Dr. Kshitij said, this could be present in the anterior canal, but more commonly it could also be what we call epigeotropic or downbeat posterior canal BPPV. So there is no torsional component, it is a downbeat nystagmus. And for these patients, we would do a Iacovillo or a modified Iacovillo maneuver. I'll be showing you that in the anterior canal portion. Now, I'd like to talk about something which is not very common, but which you need to be aware of, when this patient was taken to the Dix Hallpike position, we did not see any nystagmus. Waited there 30 seconds, nothing. But when the patient is brought back to the sitting position, we get torsional upbeat nystagmus. And what that indicates is the C position. This position is called the short arm posterior canal BPPV, and in these patients we need to do a brisk Epley maneuver, just the steps of the maneuver of the Epley maneuver which I just showed you, but in between each step often have retropulsion, they fall backwards, a tendency to fall backwards. So